This week on the BackTable Podcast.
I sort of joke with some other IRs about this because if this took like 6 hours and had like 500 cc blood loss every time, there'd probably be a line of IRs out the door to do this because they want to do the hardest, most complicated, bravado-inducing type procedure. This is the complete opposite of it. So this is even more straightforward than biopsy, right? So you're putting a needle in and you're delivering this magic potion into the tumor. So from a technical standpoint, if you can do a biopsy, you can do an injection, which means every IR coming out of training should be able to do these. There are nuances to it. There's ways to think about it to maybe optimize it. And that's what we try to build into some of the guidance that is provided on these trials and ultimately in standard of care. Like anything else, a little bit of a learning curve, but from a technical procedural standpoint, every IR can do this very, very straightforwardly.
Welcome to the BackTable Podcast. I'm Tyler Sandow. I'm an interventional radiologist at Ochsner Health. Delighted and privileged to bring on two experts in the field of melanoma and, I think cutting edge treatments. With me, I have Dr. Rahul Sheth and Dr. Jennifer McQuade. I'll give you guys a quick second to introduce yourselves and tell me a little bit, and then I'm going to probably start pinging you with questions.
Hey, Tyler, thanks for having me. Rahul Sheth, I'm an IR at MD Anderson in Houston, Texas, and it's my privilege to work with Dr. McQuade.
Hi, Jennifer McQuade. I'm a melanoma medical oncologist, formerly also at MD Anderson, and collaborated closely with Rahul. And thanks, Tyler, for having me on.
Well, now that you say MD Anderson, I will say at Ochsner, we are the Ochsner MD Anderson Cancer Center. So we are like distant cousins of you guys.
That's right.
And since we're from Louisiana, if we were to call ourselves cousins, we would be more along the cousin Eddie side. But I'm not going to show up to your house at Christmas filling up the tank outside saying shitter's full or anything like that. But we're somewhat cousins, but you guys are the experts here. And so this is cool. Today, what we're going to talk about is Replimune and somewhat along the lines of intratumoral oncolytics. And before I dive too deep down that road, Dr. McQuade, I was hoping that you could give me a brief bird's eye overview of immunotherapy, and then we'll kind of dive into intratumoral oncolytics after that. And to preface this, I would say that you got to dumb it down for me. I don't live in the clouds like you guys do, so I try to make it as simple as you would to help me understand it.
Okay. I'm sure you're with us. So immunotherapy is a class of medicine that's really just completely revolutionized the treatment of melanoma. Metastatic melanoma used to be like as deadly as pancreatic cancer. And, now with the approval of like new immune and targeted therapies, we've, taken the 5-year survival of melanoma from like less than 10% to like over, 50, 60%. And, the biggest game changer when we think about immunotherapy, the first thing that comes to our mind is immune checkpoint inhibitors. And so these are the anti-PD-1, anti-CTLA-4, anti-LAG-3 drugs. So basically, right, our immune system, goes around and it's supposed to not just help protect us from like bacteria and viruses, but also precancerous or cancerous cells. And the way that it does that is it recognizes that, when cancer cells, when the DNA, in the case of melanoma, gets bombarded by UV radiation, there's tons of DNA damage, and then they produce proteins that actually look different, like the cancer cells look different than our normal cells. But so the immune cells should be able to then recognize those mutated cells and say, okay, I'm going to get rid of you. That's immune surveillance, right? But the cancer cells have co-opted this mechanism that we use to prevent, our bodies use to prevent like autoimmune disease, these molecules called checkpoints. And so essentially the cancer cells express these molecules called checkpoints. And they, it's like putting up a brake, right? And the immune cells come around and the cancer cells are like, hey, just a normal cell here, go about your business. And so the immune system, ignores them, the cancer cells grow, right? And so there were these Nobel Prize, a Nobel Prize actually won for the discovery of these checkpoints because the cancer cells have these checkpoints. But not only that, but if we block the checkpoints, then we can allow the immune system to now come in and kill the cancer. And so with these immune checkpoint blockades and other forms of immunotherapy, it's actually not like the drug that's killing the cancer. It's actually our own immune system that the drugs unleash and allow to kill the cancer. And what's cool about that is that the immune system has memory. And so, now, just like when we get a vaccine and, now our immune system has memory. And if we get re-exposed to the flu or to COVID, if we're lucky enough to get the vaccine, then our immune system still recognizes that and can now eradicate that, virus. So same thing, right? If the patient's immune system responds to this immune checkpoint blockade, recognizes the cancer, now every time that cancer tries to rear its ugly head again, the immune system can recognize it and knock it back down. So we can actually take patients, not everybody, right? But we can take patients even with like widely metastatic disease, if they are fortunate enough where these checkpoint blockades work and their immune system takes care of the cancer, then we can effectively cure patients with mets throughout their body, brain, lung, liver, etc. They come off of the drug and they go on and, live long and healthy lives.
Yep. I would have given a Nobel Prize for that too.
Yep.
Thank you for explaining it in such a way that I could understand it. That, I think, is a cool bird's eye overview. I understand immunotherapy much better now. So intratumoral oncolytics are a little different though, right? How do they work?
Yeah, so it basically, the intratumoral oncolytics, so essentially they are engineered viral vectors. And so in the case of T-VEC, which was the first oncolytic virus that was approved in melanoma back in, I think, like 2015. And now RP1, the Replimune drug. Then with these, essentially, they are taking a modified herpes virus. So we're not infecting people with herpes, but a modified viral vector that we then, well, not me, Dr. Sheth, directly actually injects into the tumors, and it does two things. One is it lyses the cancer cells. It explodes the cancer cells. And so we're directly killing cancer cells. But, that would only work in like the ones that we actually inject. The other thing that it's doing is that when we explode those cancer cells, now we've released those foreign-looking proteins. And so we can, again, allow the immune system to now say, oh, wait a second, something's going on over there, and then recognize that. And then sometimes they have these kind of engineered domains that also change that tumor microenvironment and make it even more accessible to the immune system. And so it's more of a stimulator of the immune system as opposed to like the checkpoint inhibitors or taking the brakes off. And then what we can do is we can actually put them together.
That's awesome. So I guess, immunotherapy is this revolutionary breakthrough, right? We have changes in survival for patients with what was once a awful diagnosis. But that works a fair amount of time. When do intratumoral oncolytics get incorporated, and how does that change? Like, is there a time frame for whenever you say somebody is a candidate for RP1 or someone probably starts with immunotherapy? How does that work out?
Yeah, so if we go back to, say, T-VEC, right? So T-VEC, that one really worked in patients that have like in-transit metastases. So melanoma, as it is on the way to a lymph node, they can basically have these little deposits that kind of come up along the skin or in the subcutaneous tissue. And so it's a very specific pattern, for melanoma that's not seen in a lot of other diseases. And sometimes we might start in a patient, say, that only had those. We might start with something like T-VEC. Oftentimes we'll still start with immunotherapy, but those are ones that do well with just like T-VEC alone. Where T-VEC really doesn't work, though, is in those patients that actually have visceral organ, disease. For those patients, checkpoint inhibitors are for sure our frontline treatment. And we can give a PD-1 drug, pembrolizumab or nivolumab by itself. We don't do that a whole lot anymore. We have better combinations. So we can either give PD-1 plus an anti-CTLA-4, so ipilimumab, or there's a newer kid on the block, anti-LAG-3, relatlimab, and we can give those combinations. But, essentially, it's about a 50-50 shot in terms of whether it's going to work. So if it works, it can be great, but it only works in about half the time. And so that's when we really usually think about now coming in with an intratumoral treatment. Specifically in that case, that's where, the Replimune agent really comes in, is actually in patients that have, anti-PD-1, anti-checkpoint inhibitor resistant disease.
So you're kind of alluding to, I think, a little bit of the IGNYTE trial, right? Now, were those patients, obviously I did my research before I come in and talk to you guys about this stuff, right? I'm going to look this stuff up. So those patients that were enrolled in the IGNYTE trial were refractory or resistant to immunotherapy. Is that correct?
Correct. Yeah. So the first IGNYTE trial was a phase 1-2 study. In those, they had to be refractory to at least anti-PD-1. About 40% of those patients had also actually had PD-1 plus CTLA-4, so like Ipi-Nivo together in combination. For IGNYTE-3, which is the registrational phase 3 study, that because, again, we don't use PD-1 monotherapy a whole lot anymore, now they raise the bar even higher. And so patients actually have to be refractory to PD-1 and CTLA-4, or have had some type of, reason why CTLA-4 couldn't be given.
So basically, we're like, we head to this area where we present this incredible set of drugs where you basically change the overall survival from 10% to 50+%, or the 5-year overall survival. Then all of a sudden you tell me, well, not everybody's going to have a response to it. But then all of a sudden there's now a drug that might kickstart the immune system to make it responsive. And that's where Replimune really shined. That correct? Exactly. That was the IGNYTE trial.
You got it. You understood.
See, I might picking this up, not so much the dumb cousin anymore. Well, so great stuff. I think what I'm interested in is, how do you put this to practice? And this might be more for Rahul as well, and I'll tell you this, for those that don't know Dr. Sheth, I've run into him every time there's something cutting edge or groundbreaking or fancy and deep down fascinating, you find his name there everywhere. So he is like Mr. Integrated into everything that's cool and groundbreaking. How do you guys make this work at MD Anderson? Or how do you guys make it work in practice?
You're making me blush, buddy. So that's kind of where, when the rubber hits the road for these intratumoral deliveries, I think it's super critical for the IRs to feel engaged and part of the treatment process, because we are. So I think before we kind of dive into those nitty-gritty things, I think it's useful to think a bit about what this therapy is from an IR perspective. Like you said, it's a revolutionary new option for melanoma patients. And in this patient population who are resistant to immunotherapy, if you were to re-challenge them with, a single agent immunotherapy, again, the response rates are in, the single digits. And so if you look at that IGNYTE trial, we're talking about like a ORR of like 30% or something like that. So it's a huge improvement to, putting them back on checkpoints alone. So that's great. But what does that mean to an IR? So a couple things. And this is where, when I first learned about this field about 7 or 8 years ago, I just went all in. I thought it was so spectacular, because all of us, in IR, when the world of immunotherapy kind of blossomed in front of us, we all thought, hey, listen, I've got this tool in my back pocket, whether it's ablation or embolization or whatever, and it stimulates an immune response, right? So all of us were looking for ways to take our favorite little hammer in IR and see how we can use it in combination with immunotherapy to trigger this systemic immune response, call it the abscopal effect, call it whatever you want. And so there was tons of mouse stuff, and I've done plenty of it, and then human trials. But along comes this therapy that is tailor-made to do this. So it's not something that we've been doing before for curative intent. Let's blast that tumor to smithereens by burning it or freezing it or radiating the heck out of it. We're going to actually deliver this molecularly engineered therapy that's designed specifically for this purpose. And, lo and behold, it works. It works in ways that none of our other therapies we have on our shelf can do or even come close. Like if you look at the data from IGNYTE, and there's figures in IGNYTE, that is now the gold standard for this combination, where you can see these dramatic responses, not just in the thing you treated, but all the other spots in that patient also, shriveling up and disappearing. That's spectacular. I mean, there's nothing that we have in our toolkit that comes close to that. And I don't care what your favorite, fanciest, newest ablation modality, whatever it is that's hit the block, there's nothing that we have data to compare to it. So that gives me like chills, honestly, when I see data like that, because it's so exciting. So that's the motivation. I think that's like the selfless motivation for an IR. I think the selfish motivation is there's a whole new cancer world that we have a relevance for that we never really had before. So we're all about localized disease and let's get rid of those early stage tumors, et cetera, et cetera. But metastatic patients, we really have little to offer. And now, we are relevant across, honestly, this huge part of the cancer pie. So I think that's a critical part of motivating IRs to do it, because what I'm building up to is it's not easy. It takes logistical infrastructure, it takes effort, it takes building bridges with new oncologists and new referral teams. It takes dealing with a biological agent in your IR suite and knowing how to deal with biohazard safety, things like that. And it takes kind of corralling your own partners to drink the Kool-Aid and buy into it, because as your volume builds, it's not going to be able to be just done by you. You have to get everybody to do it, and that's not necessarily the most straightforward thing. And so I think you have to bite into a hook, line, and sinker to be able to build a practice. But hopefully I've kind of gotten you on the same side too about how cool this stuff is.
Oh, of course. I think when you and I talked about this, it had several months ago, I was in. You tell me that you can. I can find the Yeti, right? We always were hunting for that with the abscopal effect, and here it is. I think that's what's very cool. We always thought we had to destroy a tumor to get the abscopal effect. This is a simple injection, and I think that the relevance here, Dr. McQuade, you alluded to it. This is visceral disease, right? So these are no longer cutaneous injections where T-VEC, we're going to probably jump back and talk about that for a little bit, but a lot of that was nodal or cutaneous injections. And now we're talking about actually injecting solid organs or tumors in solid structures. And that stuff really can only be done with image guidance. And so it's not just something that IR can do, it's something that IR should do, something that we should buy into. We are central to this treatment, which I think is incredibly groundbreaking and revolutionary. To flip back, so y'all alluded to T-VEC. I did a lot of T-VEC early on and still kind of do, because Replimune, we're waiting for FDA approval. And so we can't necessarily, unless you're in trial, you don't have access to it. So I do T-VEC. T-VEC is cumbersome. And you're also dealing with a virus, right? So T-VEC is the predecessor to Replimune. Replimune is a modified and hopefully much more improved version of this. For T-VEC, some of the challenges that I face are I got to measure a node on the front end, have to order a dose, let it thaw for several hours before I inject it. And heaven forbid you inject it on the table, which was the first one that I ever did. I was trying to load up the needle and it spilled out, and so we had to go get a new dose. It was not ideal to have denatured herpes virus all over your table. My nurses were not happy. But how does Replimune compare? I guess so before we talk into the referral pattern and the structure with how y'all integrate, and I'm sure there's a tumor board, when a patient shows up, what's the plan? What's the structure, Rahul? How do you say, like, I'm going to inject X mLs into said tumor, or do I divide it? Do I split it up? What's the prep? What do you use? I'll probably just pick your brain as we go through it.
Yeah, so it starts with the oncologist. So it starts with Jen seeing the patient in clinic. For T-VEC, these are cutaneous or sort of subcutaneous lesions. many of them, they take care of in melanoma clinic itself. And so there's this whole group of patients who don't come to us because they don't need image guidance. But for the ones that do need image guidance, that's where that bridge has to exist, that communication and that relationship with the IR and the medical oncologist, because we need to look at the images together. We need to decide which are the lesions that we want to inject. And sometimes that changes on a weekly basis or bi-weekly basis as things respond or don't respond or new things pop up. So you have to be nimble, you have to be agile in terms of how you plan these things. And it could be you plan one thing this week and next week you have to change plans. And so that has to be kind of in your mind, your approach to it. It is also kind of, I think, the beauty of this therapy is that it is often a quickly responsive. And so you'll see things change dynamically in front of you, and one day the patient show up and you say, that spot's gone, like there's literally nothing for me to inject anymore. And that's a great feeling, right? So I think that's, just can't sort of underline enough how that relationship and that sort of communication bridge has to be the foundation of that relationship.
So I guess Dr. McQuade or Jen, I'm going to switch the first name at some point. She's the quarterback, I guess. So she's kind of making the decision about, hey, I want this patient to get RP1. And so she's going to reach out to you. Is there a tumor board? How does it work out for you guys? Is it phone conversations? Is it like, hey, I could do this? What's the relationship there, Jen?
Well, when you've got a role, you send an email and you get a response within 15 minutes, and he's like, I got it.
That's how you build a practice too. I mean, you want people to refer to that from an IR. If IRs are listening to this, if you want to build a practice, you respond quickly, and then everybody starts following up with you. You deliver and you keep delivering, and that's how it works out. So thank you for just highlighting. Now we basically sold the show here on practice building. But so how does it work out? So you get melanoma patients, they get probably referred directly to you, Jen. Then what?
Yeah, I mean, so we do, we have a tumor board where we discuss suitability for specific studies, but the selection of lesions for injection, when I was at MD Anderson, was not there at that tumor board. It's really a one-on-one dialogue between the oncologist and the interventional radiologist. And I think that the really important word there is dialogue. It's not, it's a two-way street. And, a lot of times too, it might be, well, I'm going to do this one, this time in 2 weeks, I'm going to do this one. And then, as Rahul said, it might be that, oh, well, hey, that one ain't there anymore. Now I'm going to switch and do this.
So I would gather to say you would agree, we don't need a tumor board to get this kind of thing done. I just need to be very integrated with my oncologists who practice in the melanoma world. Now, so you could do multiple lesions. You could do multiple targeted sites at one time, correct?
Yeah. So Replimune gives you pretty loose, but still some structure in terms of the injection guidelines. And so it's nice to have a little bit of direction, but it's also nice. It's not crazy prescriptive. You have to read a list of 50 things every time you try to choose a lesion. You're essentially given 10 cc's of the drug, and that's usually your rate limitation in terms of how many spots you can inject in a single session. And so you have 10 cc's. You have a very simple lookup table. Okay, if it's 3 centimeter lesion, I can inject this much volume. If it's 1 centimeter, I can just, so you just do a little bit of simple math and figure out, okay, today we'll be injecting lesion ABC, and then we'll maybe do this for 4 weeks and reassess, or because they have, see DEF, I know my alphabet, DEF, then you would inject that the next week and just kind of alternate. So you can come up with these little regimens based on how many lesions there are. It's a very simple process in terms of finding out how many you can inject. But really, like Jen said, it's about looking at the patients, trying to choose lesions. Like we think about lesions that might be causing symptoms. If it's painful, that's something to prioritize. If it's going to get bigger and cause mass effect and block a bile duct or do something horrible, then maybe that's a priority, lesion. And so, we look at the imaging, we use our, imaging skills to sort of figure out this is a problem lesion, or I need to prioritize this for whatever reason, or like that one might not be a great one to inject. That's pretty rare, to be honest. Like, we're IRs, we can put needles just about anywhere.
Especially
but we do think about it.
Yeah,
again,
exactly right. Some people are just incredibly skilled here.
That.
But yeah, that's where that relationship comes in, and choosing those spots. It's not a complicated process, but just kind of like you're saying, you got to put in the effort and put in the time to look at those scans. In the end, you can do it in 30 seconds once you get really comfortable with it. But in the beginning, put a little bit of effort in and figure out how you do this right.
So how hard is it to do an injection, right? Like, so do you use ultrasound, use CT, use both? How hard is it? What do you do?
Yeah, you use whatever imaging tool is the best one to do it. And so if it's ultrasound, so be it. If it's CT, great. I think, I sort of joke with some other IRs about this, because if this took like 6 hours and had like 500 cc blood loss every time, there'd probably be a line of IRs out the door to do this, because they want to do the hardest, most complicated, bravado-inducing type procedure. This is the complete opposite of it. So this is even more straightforward than biopsy, right? So you're putting a needle in and you're delivering this magic potion into the tumor. So from a technical standpoint, if you can do a biopsy, you can do an injection, which means every IR coming out of training should be able to do these. There are nuances to it. There's ways to think about it to maybe optimize it. And that's what we try to build into some of the guidance that is provided on these trials and ultimately in standard of care. And so there is a bit of nuance to it in terms of, what needle to use and how to inject and rates of injection and how to choose the volumes and stuff like that. So there is, like anything else, a little bit of a learning curve, but from a technical procedural standpoint, every IR can do this very, very straightforwardly.
So from I guess a tools perspective, a basic biopsy kit should get me pretty far. What kind of needle do you like to use? Do you use a 17 gauge needle, 21 gauge needle, 25?
Yeah, it depends on the location. If it's going to be in the liver, and especially if I'm going to have to reposition and go to another lesion, or I want to try to get multiple sites in that tumor to sort of distribute the drug, then I'm usually going with a coaxial needle, so either a 17 introducer or a 19 introducer, through which I'm putting my 21 or 22 FNA Geo needle, and then doing that just so that way I have a little bit more torqueability, I don't know if that's word, to use a introducer to get me into different locations. If it's just like a subcutaneous thing or a lymph node, then I usually, 21, 22 is the highest gauge that I'll use. I think 25 is a little too teeny weeny for what we're doing in image guide and stuff. I think for cutaneous stuff, I think in melanoma clinic they use 25s all the time. So that's fine. It's not like it's going to shear the virus into pieces or something. But for image guidance, 22 is about as small as I go. But that's kind of the thing. I mean, with liver and lung, I like to use a coaxial system, but you can very easily, argue that there's absolutely no need, and I'm not going to fight you over it. There used to be more options, to be honest, in terms of needles that had multiple site holes and, tines and stuff to spread out that were super clever. Those aren't necessarily available anymore. And hopefully as this field kind of continues to explode, there'll be more options. But right now, a single old end hole Chiba needle is kind of the go-to for all this.
Yeah, because it's at the end of the day, you're injecting a little bit of liquid, right? And if it's no more than a total of 10 mLs, it really isn't. It shouldn't be dramatically hard to do. Now, there are some prescriptive techniques to this, right? So you want to try to inject certain parts of it, or try to cover the entirety of it. How does that work out in terms of distributing the dose? So, let's say I got somebody who wants to start doing this in California. How would you describe, 21 gauge needle or a 17 coax or 19 coax, get it into the lesion, and then how do you inject from there?
Yeah, so usually what we try to do is, you can call it the fanning technique or radial technique, whatever description you like, but basically the idea is you want to try to deliver the drug throughout the volume of the tumor. And that just kind of goes back to the basic principles of how this medication works, where you're trying to lyse tumor cells. And so the cells of interest are the tumor cells, but you also want to sort of distribute it in the environment of the tumor where the immune cells might live, so that they can recognize those signals and be attracted to that area and, recognize those antigens, et cetera. So tumor, if you assume the immune cells are sort of randomly distributed throughout the tumor, which I think is a fair enough assumption, you just kind of want to spread the volume out as much as possible. Also, kind of along those lines, you try to avoid areas of necrosis. That's easier said than done sometimes, but certainly there's not a whole lot of action in the necrotic center of a tumor. And most of it is on the viable, periphery of the tumor. So those are areas that you want to prioritize, and you do that fanning thing just to spread it all around. Those are the main take-home points in terms of technique. You could get more into the nitty-gritty, but to be honest, it's all just kind of speculative, in terms of what's better than just following common sense stuff.
Yeah. So I guess to describe it for people at home, when you talk about fanning, you would probably put the needle in maybe the deeper portion of a lesion or off to the side, and then pull back, but not come all the way out of the lesion, and then try to twist the needle into different areas of the lesion as you're distributing somewhere between 3 mLs or 5 mLs worth of fluid, correct?
Yeah, that's better than I could have done. I think the other thing you mentioned, which is worth mentioning, is try not to puncture the tumor capsule too many times, because those are just more holes that the liquid can leak out of. So get in there once, and then, like you said, go all the way in, deliver as you pull back, then find a new trajectory without coming all the way out of the tumor, deliver as you pull back, and just do that a few times to get all that juice in there.
Gotcha. So simple biopsy tray, 21 gauge needle, inject the fluid, you're out. That's easy, right? And that's cool. We should probably make it sound more complex so more people want to do it, but it is probably the easier thing that we do. Now, this question should come up anytime that we're trying to introduce a new concept to an interventional radiologist. Some people are cowboys and they just don't care. Some people are a little bit too cautious. What kind of safety profile am I dealing with? So like, what's the likelihood that I'll harm somebody by doing this? Jen, can you help me out with the safety profile associated with RP1? Like, is this something I need to be like terrified of?
No, it's a really safe drug. I mean, sometimes we'll have some kind of fevers and chills. If you have, if you're doing something superficial, then you might see like a local injection site reaction, but they're really safe drugs. And then it's combined together with anti-PD-1 and, not seeing any additive toxicity or any synergistic toxicity there. It's like you have kind of the injection site, and then you have your usual stuff that you get with checkpoint inhibitors. But that usual stuff with checkpoint inhibitors, none of that is acute, right? That's all stuff that the oncologist manages when it comes up.
So to me, we've now described an easy procedure with a very safe profile. It's kind of like this should be something that should be widely adopted, right? There should be very few barriers to introduction from any interventionalist, because it seems like I could put a needle in anything. I know how to inject a little bit of dose into anything, and patients tolerate this well. It's kind of like, why aren't we doing this? And I think as we start to get these trials come to fruition, we'll start to see some hopeful good buy-in from the FDA, I would assume, to ignite this thing,
There you go. Nice.
Ignite it.
We thought that was going to happen in the fall. So
I'm with you, but I'm still convinced that this is the way of the future. And I think that these oncology IR integrations, as we get further along, are only going to be more important. I guess, so now we've talked about the injection, we've talked about the safety profile. How do you manage response to treatment? Right? So at what intervals do you image patients? Are there things that you look for? Are there things to not get confused by? How does that work out? So tell me how you do it.
I mean, it's, so basically within the trial, I can't remember, but it's usually, somewhere between 6 and 12 weeks is when we get our restaging. In trials that have like a 6-week look, we just want to make sure things aren't rapidly progressing, and it's usually really at, 12 weeks. With RP1, it can work fast, right? But it doesn't always. And, so that's fine. If something's growing a little bit, right? It could also be a bit of pseudo-progression. That's fine. And so we really don't want to call, unless somebody has, really frank progression. We don't want to call it with that, with that early scan. And again, it might be if we have stuff that is stable and then we kind of have that mixed response, which is certainly possible, and it might be something that we didn't inject, then maybe that one, that growing lesion gets injected the next time around.
What kind of scans are you getting? Is it PET? Is it CT? So
either is fine. When I need a PET is really, if I have any type of, extremity stuff, then I either need a PET or I need to make sure that I'm also getting CTs of the limb. But otherwise, a CT is completely fine to assess. And we certainly, even if it's a PET, we need to make sure that on that PET, There is a good CT component that goes along with it. So there we're getting a quality measurement, to see that change. But it does not have to be a PET.
Now, you alluded to this, and I do want to, I'm sorry, Rahul, were you about to?
I was going to say, Jen brought up a point, but I think it's worth kind of diving into it a bit more. The concept of pseudo-progression. So this is like
that was what I was going to do. You just beat me to it.
Like my hands, buddy. So pseudo-progression is something that we in IR don't really think about. And, when we get a follow-up scan after a local therapy, if that tumor is bigger, we're not happy. This shouldn't look like that. And so being patient and sitting on your hands is, I think, really hard for us. But when you look at, I think in general, immunotherapy, but even specifically like the IGNYTE data, there's a good number of those tumors that all got bigger before they started getting smaller. And so that's, I think, a really important take-home message, which is like, just because it's getting bigger doesn't mean, all has failed and it's time to move on to the next line. Just sitting on your hands and seeing how it how it changes on the next set of scans is like super important.
Awesome. Thank you. And we are like-minded, brother. So what's coming down the road? We obviously are in the field of melanoma. There is, in my opinion, incredible evidence that supports this. But what else coming out? It's because it's not like melanoma is the only, it was the one that kickstarted the immunotherapy regime. But there are a lot of tumors that respond to immunotherapy. So what's coming down the road with intratumoral oncolytics?
Yeah, I mean, I think that's what's exciting about RP1, right? Is T-VEC, you end up limited really to melanoma because that's the thing that has these dermal metastases. But, if we're dealing with a cancer, if we're dealing with visceral metastases, then any metastatic cancer has that. The question is the RP1 enough? Or in some of these more immunologically cold tumors, Replimune has kind of their second drug in their pipeline, RP2. So now you have also engineered in an anti-CTLA-4 domain. And so that is actually in a phase 3 trial in uveal melanoma, right? So as opposed to like ipi-nivo response rate with cutaneous melanoma, 50-60%, with uveal melanoma, 10%, right? But the RP2 drug actually looked pretty darn good there. They're also looking at RP2 in HCC as well, but I think kind of hopefully after, melanoma regulatory approval, I think we're expecting a decision in late spring. Hopefully after that, right, then kind of open up to other solid tumors.
I mean, just like you said, Tyler, all good things seem to start with melanoma in terms of these immunotherapies. So checkpoint started with melanoma. Cell-based therapies like TIL started with melanoma, oncolytic viruses started with melanoma, and then spread to other tumors from there. And so, I'm a huge optimist. I think we're seeing the beginning of this wave of intratumoral immunotherapy, starting with melanoma and then spreading out. Like Jen mentioned, HCC. There's trials in there, many other tumors as well, up in the chest, lung cancers. There's some kidney cancers, things like that too. So people are looking at this. And as we talked about at the beginning, this is all sort of tumor histology agnostic. It's about activating your own immune system. And so from that standpoint, it shouldn't be specific to one tumor, like some, molecular therapy that only finds one specific mutation. This is really about your own immune system and how to get it activated. And so in that sense, it's kind of irrelevant what type of cancer it is, to some extent.
I mean, it's true. And it's true, right? Like, so at some point, we're going to have to figure this thing out. You're going to have to be able to do Replimune, which is really, you've just made it sound incredibly simple. And I believe you with that. So, but it's not like it's going to go away. We're going to see it once it gets approved with melanoma. We're going to see it in HCC, and we're probably going to see it in other cancers that are responsive to immunotherapy. So I think that's the cool thing, right? Like and as you would expect, Rahul Sheth, the man who is on the front line of everything that's about to be revolutionary, as you would expect, he's right here talking about something that you're probably going to hear be common discussion 5 years from now. I think we're getting close to the end of this. If you guys could give me some tips, so this is an IR Central podcast. Can you give me a couple points about what you would kind of close with? What kind of things do you think are critical for us to kind of just sum this whole thing up? I think, Jen, I'm going to steal it. I think collaboration might be the one thing that if you could take away anything from this, I'm going to steal yours. The communication is the biggest practice building tool any interventionalist could have. Responding quickly, responding with a discussion, open dialogue, and also confidence that I can take care of the problem that you have. To me, that's a great practice building tool. But what other kind of points would you guys give us on this Replimune focused podcast?
Actually, I think I would give it over to Rahul in terms of, I think one question that we really didn't talk about is, say a patient has liver mets and lung mets and, subcutaneous mets, has mets in multiple visceral organs and, some easily accessible like subcutaneous or nodal disease, like, do you just go for the easy stuff and just, inject subcutaneous? Do you try to, do some lung, some liver, some this? Like, how do you actually think about that?
Yeah, I think it's a great question. As we've discussed over patients, easy is always better, but that being said, I think there is a biological rationale for treating tumors in their specific niches. And so those melanoma cells that went to the liver are probably slightly different than the melanoma cells that ended up in the lung and the ones that stayed subcutaneous. And maybe they developed some metastatic potential, but the ones that didn't leave the subcutaneous compartment never did. And so there is, I think, a good biological rationale and potentially some clinical data as well that help, inform us in our lesion selection. And so, yeah, nice to inject sub-Q tumors, super easy, takes, 5 seconds. But there, I think, is a lot of value in injecting those visceral lesions as well. In addition to that, because they are sort of exposing the immune system to a slightly different potential clone of the melanoma cells that are maybe a little bit more malignant or more aggressive or whatever. So I think it makes sense to do that and maybe take 5 minutes to 5 seconds. But still, it's I think worthwhile to do that.
That makes a lot of sense. And I think that's an incredibly helpful tip right there. What other kind of tips would you give IRs? What would you tell us about keep it simple, make life easy, sum it up for me.
Yeah, I would say most important, get excited. I think this is something that honestly is being hand delivered to us, this kind of golden ticket for the next phase of immunotherapy. And we are front and center in it. And so, sort of take advantage of that, show what you bring to the table, work with your oncologists, hustle, do the legwork to get your program off the ground. But then you literally will have a seat at the table at, I think, the most exciting, revolution in cancer care. And so I think get into it.
All right, guys. Well, look, thank you so much for being on and entertaining me and really kind of exposing us to what is probably going to be the future of cancer care down the road. We're just getting an early sneak peek in the melanoma world, but I have a feeling this is probably going to be something that is going to be popping up more and more in other cancer lines in the future. You guys are wonderful. Obviously, you're the leaders in this cutting edge field. So thank you so much for your time. Look forward to running into you guys soon. Obviously, I'm always going to see Rahul at all of these conferences because he's the cutting edge man who can do anything with anything. But Dr. McQuade also hopes to run into you soon too. Thank you guys. Hope you have a wonderful evening. You take care.
See you, man.
Thanks for having us. That was
You
fun.
too. Thank you all.
Take it easy.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.